All right. Hello, everybody. This is our first lecture in our neonatal pediatric respiratory disorders. This covers it's actually chapter 35 in your Egan's 12th editions. And this is just a good chapter to review because it really discusses a lot of the different pulmonary disorders, respiratory disorders that we can see in newborn and pediatric patients. So a couple learning objectives I'm clicking through quickly. Okay. And then, as you guys are going to understand from NRP and PALS discussions, a lot of um, kind of disorders for younger children really have a lot of effects on the respiratory systems. So, some of these disorders are going to have some abnormalities in the heart and the lungs and the airways. That are due to just underdevelopment, which we kind of learned about that a little bit in our first couple sections of this course. Some of the problems are going to be caused during labor and delivery, stress during labor and delivery, and some of them are going to be kind of genetic conditions that are going to affect the baby's development of their lungs and their heart. So when we're talking about neonatal respiratory disorders, kind of the main category of neonatal respiratory disorders are going to be kind of categorized as disorders of the lung parenchyma, which is kind of the lung tissue. So the first one that we're going to kind of cover is respiratory distress syndrome. This is very similar to adult respiratory distress syndrome, where you have airway inflammation, collapsing of those alveoli. We'll also discuss in this section transient tachypnea of the newborn, which usually is due to like leftover fluid in the lungs that the baby kind of has to work out before their breathing can kind of become normalized. Meconium aspiration syndrome, and then bronchopulmonary dysplasia, which is kind of a long-term or chronic changes to the lung tissue that will affect the patient as they age. So, respiratory distress syndrome. This used to be called hyaline membrane disease. I think most people call it infant respiratory distress syndrome now, IRDS. So this is a disorder that is characterized by insufficient surfactant. So babies are born prematurely, and they are not able to produce enough surfactant to neutralize surface tension in their alveoli and their airways start collapsing. So that's going to cause a decrease in surface alveolar surface area, and it's going to impact their oxygenation. This also tends to lend itself to patients developing a kind of poor lung compliance and then a patent ductus arteriosus as well. So, as when you're getting called to deliveries where you suspect RDS, you should, your more at-risk patients are going to be the patients that are born more prematurely or at lower birth weights. So, the younger the baby is, the more the risk there is to being born with IRDS. Okay, so our main complications with this disorder are going to be that increased oxygen needs and the increased pressures that we're going to need for ventilation because of that decreased lung compliance. So that alveolar because they don't have enough surfactant to keep them open, are going to be unstable. They're going to tend to collapse. That's going to lead to atelectasis. And then because we have that atelectasis, we're going to have worse and short work breathing. Um, so you also are going to have that increase in surface tension that might draw some excess fluid into the alveoli, which then can cause some edema. That's going to be combined with that difficulty with oxygenation. So the patients are going to be hypoxemic, which is going to lead to an increase in that pulmonary vascular resistance. So remember, with fetal circulation, when a baby is born, we need that systemic vascular resistance to increase, that pulmonary vascular resistance to decrease in order for that PDA to close. So because of that hypoxia is going to cause increased pulmonary vascular resistance, which is probably going to lead to that more likelihood of having that patent ductus arteriosus or that right to left shunting in the body. So all of these things kind of co-contribute to each other to kind of create this downward spiral for the patient. So unless we kind of intervene and correct this, do some surfactant replacement, these things are just going to escalate and get worse. Okay, so this is kind of a nice flow chart that your book put together that kind of shows you in kind of an algorithm form what the process here is. So we start with that decrease of surfactant production due to prematurity. That's going to increase our surface tension. That's going to cause atelectasis and fluid leakage, so pulmonary edema, which is both of those lead to hypoxemia. When you have hypoxemia, that's also going to lead increases your chance of acidosis, which is going to increase your chance of pulmonary vascular resistance. So your increased PVR, more right to left shunting, and this becomes kind of a cycle. Just like the atelectasis increases that ventilation perfusion mismatch, meaning that I'm going to have perfusion to underventilated tissue, which is going to lead to that increased work of breathing and hypercapnia, which leads to acidosis. That fluid leakage can lead to that hyaline membrane formation, which means that you just have a lot of edema in your lungs, which is going to contribute to the hypoxemia as well. So I kind of actually really like this algorithm because it kind of goes through how this process, is kind of linear, but also cyclical, that these patients, if we don't do something to intervene here, this is just going to get worse and worse and worse and worse and worse until the point that you're not going to really be able to ventilate the patient. Okay, so how do these patients present for clinical manifestations? So the first signs of that respiratory distress are usually going to appear very soon after birth. So if you got IRDS as your neonatal care plan, one of your subjective symptoms is that this is going to show up very soon after birth. This is not going to be something that, happens later on. This is going to, right at birth, we're going to see signs and symptoms of this. Okay. That tachypnea is usually the first sign that you're going to see. The patient's going to be breathing rather quickly. Then you're going to see that as kind of other signs of increased work of breathing, like retractions, paradoxical breathing, grunting. You can also see that nasal flaring. Typically on auscultation, we're going to see here those fine inspiratory crackles. Again, fine inspiratory crackles indicate atelectasis, those opening and closing of those alveoli. Okay. Cyanosis is always kind of, like I said, kind of a subjective assessment. You may or may not see it with these patients, but these patients do tend to have poor oxygenation. Usually then they're going to do that definitive diagnosis with a chest x-ray. So if you're getting this patient on your ClinSim exam, typically I would pretty much almost guarantee that you're going to get an RDS patient on your ClinSims. You're going to want to get a chest x-ray for these patients. And then your chest x-ray is going to come back with diffuse, hazy, Kind of the key terminology is that ground glass appearance or reticular granular densities. And what that looks like is you see these little, like, if you, I always like relate this to impressionist paintings for those of you that like art. George Seurat is a big impressionist painter, and does all the little dot paintings. Um, and so if you're looking at this chest X-ray, the haziness in the lungs, if you look very closely, look like a bunch of little dots, because that's essentially what they are, those collapsed alveoli, those little dots from the collapsing of the alveoli or the filling of those alveoli with fluid. Looks like a ground glass appearance on the chest X-ray. Air bronchograms is another thing that you might see. So air bronchograms, what this means is I'm gonna go to the next slide here because I've got some chest X-ray hairs. So if I would zoom in on this picture here, you see these lines, these dark lines through this hazy lung field. These are air bronchograms. Okay, those air bronchograms are those kind of passageways that so if you think about what your bronchioles are, those are the air passages in our lung tissue. So these air passages are really filled up with air because that air can't go into the alveoli because the alveoli is collapsed. So that air gets trapped in the passageways. So the passageways then get kind of enlarged because of that trapped gas, and they look like these dark lines within the chest X-ray. So this was an actual, this was a question on an MBR, the mock exam, is what disorders would you see air bronchograms on? So you can see it. I, you know, I kind of felt like that there could be two potential answers to that question, like bronchiectasis and pneumonia. But think about it this way: anything that's going to fill the alveoli up with fluid is going to make it so that the air can't go from the bronchioles into the alveoli. So then it gets trapped in the bronchioles and kind of hyper expands those bronchioles. So pneumonia would be an example of that. ARDS can have them happen because of the pulmonary edema. And then, what's the last one? Pulmonary edema. Oh, pulmonary hemorrhage is another good example of a disorder that's going to cause these air bronchograms because those alveoli get filled up with fluid or are collapsed or filled up with blood or mucus, and the air that comes in gets stuck in the passageways and can't enter those alveoli. Okay, so treatment for IRDS or respiratory distress syndrome. So typically our first choice with any, especially premature babies, is to not put them on invasive ventilation, but non-invasive ventilation. So CPAP would be what you would be picking first. Again, we use nasal prongs as our preferred method. If they fail your trial of CPAP at 4 to 6 centimeters of water pressure, then you can recommend intubation and mechanical ventilation. So an indication for that is if the oxygenation doesn't improve on the CPAP, or if their work of breathing doesn't decrease on the CPAP, you would then choose to intubate them. All right. So kind of think about this just like you would with ARDS for adults, is our goals are to prevent that alveolar collapse. So what do we use to kind of keep those alveoli stable is PEEP. So we're going to use PEEP to stabilize our alveoli, keep them from collapsing. We want to make sure that because we're stabilizing them, keeping them from collapsing, that means that I'm going to have adequate alveolar ventilation. So we're going to choose our optimal PEEP. That's going to be based off the PEEP that's going to provide the lowest PaCO2 and the highest PaO2 without any complications like decreases in our blood pressure. You can choose high frequency ventilation. also for RDS. So RDS with high frequency ventilation is an acceptable choice as well. Um, you wouldn't necessarily pick um, high flow nasal cannulas necessarily, because high flow nasal cannulas, you can't guarantee that PEEP, to make sure that you prevent that alveoli collapse. So high flow nasal cannula probably wouldn't be um, the choice in a severe patient. So severe patient meaning that they have a lot of work breathing, their FiO2 is above 40, or they're having a lot of apneas with this. Okay. Um, so some of the treatments that additional treatments that we would order for these patients would be surfactant replacement. We are going to instill surfactant directly into the trachea. This is indicated for any RDS patient. It's kind of the preferred treatment. So these surfactant replacements are either manufactured surfactants or animal surfactants that we instill directly down the ET tube. So you're not nebulizing it, you're just injecting it directly down in the ET tube, bagging it into the lungs for kind of disbursement, and then that's going to decrease that surface tension. So common surfactants that are available are like Survanta, Infisurf, and Curasurf are kind of the common ones that are out there. Surfactant's extremely expensive. It's like $1,000 a cc. Typically it's given, depending on the brand that you're using, you could be giving it every 6 hours. And it's dependent on the brand, what the dosing is. So, like I said, very expensive treatment, but extremely effective in, treating RDS. I think I shared in the past, like when we talked about evidence-based medicine, that this is, if you ever want a good respiratory read, the the initial trials for surfactant were remarkable in the sense that it was one of those trials that ethically they couldn't proceed with the trial because the outcomes for the babies that received surfactant were so much better than the babies that received placebo, that they stopped the trial early because it was unethical to continue with the trial and withhold this life-saving medication from babies that were getting put into the control group with the placebo. So surfactant really, honestly, is one of those historical markers in respiratory neonatal care. As prior to surfactant, most babies that were born less than 28 weeks did not survive. After we developed surfactant, we've now been able to save babies less than 22 weeks. So it's one of kind of those remarkable medical breakthroughs. So interesting study if you want to take some time and read some history. Okay. So, and I mentioned already that high frequency ventilation is also a good method of ventilation for patients that have RDS. So high frequency would be something that you would recommend in babies. Excuse me. Okay, so transient tachypnea of the newborn. So sometimes it's called type 2 RDS. Actually, I had never heard of this called type 2 RDS until I read this in Egan's a couple of years ago. So that was new information to me. I've always heard it referred to as TTN. It's probably the most common respiratory disorder in newborn. It usually happens to more of the term patients. So when you're looking at your kind of epidemiology, these are, whereas RDS is in your preterm babies, your TTN is in your term babies. Babies don't have to have any necessarily predisposing factors. I've heard some people say that, babies that are born via C-section are more prone to TTN because of that squeeze during the birthing canal. It gets rid of some of that excess thoracic fluid. I had a neonatologist once give me a long bedside lecture about how he doesn't believe that's true. um, and that it's just the hormones that are released during pregnancy that help with absorption of the fluid. I never wasn't gonna disregard something that Dr. Millville ever said to me. So I actually did not look that up to see if that was true or not true, but he really believes that that's the thoracic squeeze thing is bogus. But so what kind of the theory behind transient tachypnea of the newborn is that there's excess, amniotic fluid that doesn't get expelled through the lungs during the birthing process or reabsorbed into lung tissue, and then that fluid in the lungs causes tachypnea. So clinical manifestations then make sense that it would be tachypnea. These babies are more term babies. They're breathing a little bit faster. They usually are able to compensate for this pretty well on their own. So their pH and their CO2 are relatively normal. Your chest radiograph, Egan says it may look like may look normal, but I would say one of the most common radiograph findings that I've had in TTN babies is that perihyalo streaking. So you're going to have that you're going to see in that mediastinum area, kind of a streaking of like that white opacities, that fluid from that mediastinal area where that fluid is, and then those main bronchi and those kind of branching into those subsectional bronchi. I've never seen it look like pneumonia. I guess technically it could. You could have some hyperinflation from blocked airways, but mostly I see this looking like pleural effusions with that perihilar streaking. I'm kind of the school of thought that these babies are going to work it out on their own. One of the neonatologists that I worked with in Milwaukee would always say that, like he'll figure it out, he'll work it out. And we wouldn't really put these babies on a lot of support. So typically, if you're going to do anything, we're going to do very low flow oxygen, either with an oxy hood or a nasal cannula. They may benefit from CPAP. You might hear the babies do a little bit of grunting from that TTN. So they may benefit from a little bit of CPAP if you hear a lot of grunting. If you're having a hard time differentiating this between pneumonia, you could use antibiotics. Again, this is something that's going to appear right at birth. You're going to have that TTN showing up right at delivery. It's not something that develops later on, a couple days post delivery. It's something that you're going to see right away. It technically could be hard to differentiate between pneumonia. Babies can have congenital pneumonia and be born with pneumonia. So if it appears like pneumonia on a chest x-ray, I would say that ordering those antibiotics is probably appropriate, just to make sure that you're not missing that diagnosis. And then the other recommendation is just changing the patient's position to help speed up that fluid clearance. Usually babies respond pretty well to either no treatment or any treatments that we end up doing. And they usually work their way out of this within like 24 to 48 hours. So typically TTN, if the baby's still exhibiting symptoms of this past 72 hours, then it probably isn't TTN. So you would look at other possible diagnoses. Sorry. Okay. Meconium disorders. So this again is more seen in the term or near term infants. It's usually associated with some sort of fetal distress during labor. So perinatal depression, meaning that during that laboring process, you're having those low heart rates, or asphyxia in the fetal situation where they have a nuchal cord or a true knot in the cord, and that's causing asphyxia or prolapse cord. So any type of stress in utero is going to cause the baby to pass meconium, which is their poop, their first poops. So the three primary problems with meconium aspiration. So if they pass the poop into the amniotic fluid and then they breathe that poop into their lungs, they could have some pulmonary obstruction due to the mucus plugging. That's probably the first thing that we're looking for. There could be some lung inflammation and damage due to this like chemical injury. Obviously, anytime we aspirate anything, you learn this back in disease about aspiration pneumonia. That's bad news for the patient. That's going to cause a chemical injury to the lung and inflammation. And then these babies also at really high risk for developing PPHN. A lot of mech babies can end up on ECMO because of this, because of that pulmonary hypertension. And that's just due to that hypoxemia at delivery that's going to cause that increase in the pulmonary vasculature and PPHN. So there's chemicals and there's toxins in the poop are going to cause that inflammatory response. And this is kind of a little bit about like how ARDS works. Like, I don't know if you guys have picked up on this yet. I think we probably talked about it to you in disease when we talked about ARDS, or if you've, dived when you had any of your case studies. A lot of you guys have had COVID patients as case studies. When our bodies have like an inflammatory response, sometimes our body's defense mechanisms are our own worst enemies. Like when our body triggers its defense mechanisms, they send these inflammatory responses throughout our system, and it just starts attacking everything. And sometimes it's referred to as a cytokine storm, where everything just gets attacked, everything's activated, and you have like this like overwhelming inflammation of the body, which is going to cause, obviously, inflammation in the lungs is really bad for oxygenation, bad for gas exchange. That can kind of just cause this downward spiral and make it really difficult to ventilate these patients. And that's why a lot of these patients, when they're bad enough, end up on ECMO. So if you look at this diagram that's in your book, it's talking about like this meconium aspiration, where at rest, this meconium isn't causing an obstruction. During inspiration, these airways get pulled open so air can get in. But during exhalation, those passageways get narrowed. Airway resistance increases during exhalation, and that causes this gas trapping here. So a lot of times that's another thing you should be really on the lookout for with meconium aspirations patients, is that this hyperinflation from the gas trapping can easily lead to pneumothorax, tension pneumothoraxes. So if I was taking my clinical simulation exam, I would be very concerned when I got a meconium aspiration patient that the next step was going to be the patient had a pneumo and how would I treat the pneumo. So how do these patients present? So typically you get in the history that before birth, they are going to have, thick meconium present at delivery or when they break the bag. So they might have gasping respirations. They could be tachypnic, they could be grunting, having those retractions, anything that indicates increased work of breathing. On the chest x-ray, usually they report this as irregular pulmonary densities, which means atelectasis, or hyperlucency areas, meaning hyperinflation. Okay. So due to that gas trapping. So the ABG's hypoxemia is going to be our main problem. And because they're going to be hypoxemic, they can end up with mixed acidosis, meaning that combined respiratory metabolic acidosis due to that PPHN. So for treatment of these patients, when we covered NRP and in the beginning of the course, we talked about how the old rule was that if the baby came out floppy and not vigorous after and had presence of meconium staining, we would always intubate them and suction below the cord before stimulating the baby. We'd repeat that if necessary. This is not a firm recommendation anymore or a strong recommendation anymore. They say that it's like you can consider doing this, which sometimes I feel like is their way of getting around the fact that, um, obviously if you're at a level 3 hospital with individuals who are used to intubating patients easily, rapidly, I would say that those places should kind of stick to the old guidelines of, suction below the cords, see if you get anything out. But places where intubation probably isn't going to be as smooth due to like inexperience, which is fair. Like if you don't have to intubate a lot of babies, that, this is, intubations aren't necessarily just easy unless you've done a lot of them. So in those types of scenarios, it might not be worthwhile to attempt an intubation if you're not very confident, because you're going to just stimulate the baby and cause meconium to be aspirated out into their lungs with stimulation during the process. So they no longer make this like kind of a firm recommendation, but you can consider it. They also will attempt putting these patients on CPAP. These patients also tend to end up on sometimes high frequency ventilation, and can be put on mechanical ventilation. Surfactant is an interesting, consideration. There's not a lot of evidence out there to say that using surfactant is necessarily going to help with meconium aspiration unless there's evidence of surfactant deficiency. So some other things that you might want to consider doing is, nitric oxide therapy. So remember, nitric oxide is a vasodilator. If we mentioned that meconium aspiration could cause PPHN. So if you suspect PPHN with your meconium aspiration, you would want to start nitric oxide. That's going to dilate the pulmonary vasculature, decrease your PVR, increase that perfusion to the lung tissue, and improve gas exchange. Your book also, I think, talks about corticosteroids. So you could potentially, actually, we really wouldn't consider corticosteroids. Corticosteroids really haven't shown any effectiveness in treating patients with meconium aspiration. So primarily you're going to be suctioning these patients, potentially putting them on CPAP, intubating them, nitric oxide if you suspect PPHN as well. So if you want to try nitric oxide, you can put them on it. 20 parts per million is the recommended dose for babies. If within 20, 30 minutes you don't see an improvement of oxygenation, I would start weaning it off. So remember, the bedside indication for PPHN is those pre and postductal sats difference of greater than 10%. So if I put a preductal sat monitor on, SpO2 monitor on the right wrist, and then I put another pulse ox probe anywhere else, I will have a pre and postductal. The right wrist is preductal, everywhere else is postductal. And if there's a 10% difference between the two, that usually indicates that the patient has PPHN, and you should start nitric. This is an example of a chest x-ray of a patient that has meconium aspiration. So you see these patchy infiltrates over here on that's the right side. But you also see these kind of dark circular areas here. This is Honestly, if you guys remember what your chest x-rays were looking like last year when you were looking at emphysema, this is kind of what emphysema looks like. These are sometimes referred to as blebs, where you have these kind of circles where that air, those alveoli are hyperinflated, and you see these dark circles. So that is what meconium aspiration chest x-ray looks like. All right, so bronchopulmonary dysplasia. This is usually seen in babies that are preterm. This usually develops into kind of a chronic pulmonary disorder. So preterm babies that have RDS will develop a chronic pulmonary disorder called BPD, or bronchopulmonary dysplasia. So this is, kind of the start of this is just like RDS, lung injury, inflammation from too much oxygen, positive pressure, enough surfactant is going to cause alterations in that lung development. Remember, our lungs continue to develop for 18 months after birth. So a lot of alveolar development happens after birth. And if we are injuring those alveoli as they're developing with a lot of positive pressure or a lot of oxygen, babies can develop BPD. So they used to define BPD as any patients that were going to need oxygen for more than 28 days. They kind of divided into a mild, moderate, severe category. Most babies with BPD do improve over time, again, as they develop healthy lung tissue as they age. They can kind of age out of the symptoms with this, but obviously, the more severe the disorder, the more positive pressure and oxygen we need to use early on in life, the more difficulties the patient's going to face. Okay. So this is kind of a chest x-ray example of a patient that has BPD. You're going to see some areas of scarring, atelectasis. So this is kind of these areas of atelectasis and scar tissue. You can see areas of emphysema and cysts. So the areas of emphysema would be these kind of hyperinflated areas. This one especially right there, that one's a bad one. This kind of looks kind of blebby over here too, where you have these dark, and again, I always feel like it's easier to sometimes take a lean back and look from farther away. You're going to be able to identify those areas of hyperlucency better. So right here, I actually am going to draw on it so you can see it better. See what I'm looking at. Okay, so, oops, sorry. So right here, this is a bleb there. If I lean back, I can see areas of emphysema right here, right here. Really, right here is bad. And here. Okay, so those areas where this lung tissue, those alveolar walls are kind of destroyed and very, very hyperinflated. So these patients are really, if you think about this in terms of lung compliance, these areas of lung compliance are very low. Like very high lung compliance, meaning that air is easier to get into these areas. That's why the air is getting here. So they become hyperinflated. These areas here are areas of lower airway resistance. So up here, this is low airway resistance, decreased, my God, I'm not talking right. Decreased lung compliance here. These blue areas that I circled are increased lung compliance areas, which just shows you how difficult it would be to ventilate this patient. Because obviously my goal as a respiratory therapist was to be ventilating this lung completely equally. So that the same amount of air that came into here, right? But because these two sections have different lung compliances, these patients can be very, very difficult to ventilate because anytime I add any pressure to this lung, the the volume is going to want to go to the blue areas and not the green areas. Okay. So our goals with treating these patients and dealing with these patients on the ventilator is to prevent any adolect trauma or volu trauma or any further of that. So we want to establish a good kind of inflation level to the lungs, or an FRC, in that delivery room. So we want to make sure that we're maintaining lung recruitment throughout all lung fields. We can do that by giving surfactant early on in the delivery room. And then furthermore, we can do that by monitoring our pressures and our oxygen usage after that surfactant. So remember, when I give surfactant, I am going to change my patient's lung compliance drastically. And surfactant is pretty instantaneous gratification. Like, you give it and things get better right away. You don't have to wait. It's going to be, I've given it, and now within minutes, my patient's lung compliance is drastically better. So this is something cautionary to talk about. Is, you remember, we just talked about mechanical ventilation. We use positive pressure ventilation in babies. We use pressure control. So if I don't even know how to do this through video. All right, let me think. So let's say I have these lungs. These are my pre-surfactant lungs, and they're blue. Okay. My lung compliance is decreased in these lungs. Okay. So that means that to deliver the volume I want, I need more pressure. Okay. But remember, I'm in pressure control. So this is what I've set. So now, after I give surfactant in green, my surfactant lungs are much better inflated. Okay. So my compliance is increased, which means that to give that same volume that I gave before, I need to lower my pressure. Okay. And again, this is what I'm setting as my pressure. So if I have my patient set on a ventilator of, let's say, 20/5, okay, before I give surfactant, that's giving me, let's say, 4 milliliters per kilogram. Okay. After I give surfactant, if I don't change this 20/5, after I give surfactant, that 20/5 pressure could potentially be giving me 8 milliliters per kilogram. Okay. And that increase in volume is going to cause volume trauma, and, barotrauma on the patient, right? So we want to minimize that lung damage. So we need to, after we give surfactant, monitor the patient carefully, make sure that their volumes are still appropriate for them. Their volumes are appropriate. Their pressure settings are appropriate. And that, again, if you think about this patient here, pre-surfactant, versus this patient here, post-surfactant, because of the atelectasis that they're experiencing pre-surfactant, their oxygen needs are going to go way down after we give that surfactant. So I need to stay put at the bedside after I give surfactant, and, be there to wean the PIP and wean the FiO2 pretty quickly. Okay. Giving surfactant is never a quick process in the NICU. You have to give it, which is rather quick. You should be giving your dose of surfactant over 2 minutes and be done. But then you want to stick around. You don't want to leave that baby. You want to wait for them to stabilize, adjust your settings before walking away. You can potentially, because that fluid leakage, that pulmonary edema that's associated with RDS, is going to create more risk of volume trauma, atelect trauma. They typically will give these babies diuretics kind of early on. They might give antibiotics if they suspect any pulmonary infection to treat any inflammation that way. Chest physiotherapy should always be recommended anytime you suspect the patient has any type of retained secretions. Um, Bronchodilators are a hard one. Um, they can be used. Again, there's not a lot of really strong data out there that say that bronchodilators improve anything for babies. So, you can do it on a trial basis. Steroids have been suggested. I would say that I have seen steroids be helpful in that short term um, lung function. So the steroids we typically are using in our babies are usually more like systemic steroids, like dexamethasone is probably Decadron is the other name for that. It's the primary one that we use in the NICU. So doing a course of Decadron, and then usually that helps us wean the patient off the vent pretty quickly. Um, there's not a lot of data out there to say that using steroids is going to help with like long-term outcomes. So we might get the patient off the vent, and they might look better for a little while, but ultimately it's not necessarily going to help us reduce the amount of oxygen the patient needed or their length of stay. Um, the other thing with steroid use is that um, there is a lot of um, side effects with steroid use. Obviously, it affects your blood sugars, it affects other things in the body, so they should always be used cautiously. Nitric oxide is another one that's kind of on the fence. It may be useful, kind of controversial. I actually participated in a study for nitric oxide in prevention of BPD. And I hate to say, our study outcomes weren't very strong, saying that nitric had a tremendous impact on reducing BPD rates. So let's look at this. All right. So that I'm gonna actually maybe I'll do control of breathing. Yeah. I'll do control of breathing and then I'll stop this lecture. Okay, so control of breathing, this is where we're talking about things that affect, mostly it's apnea prematurity. So this is, those neurological controls that tell us that when we're supposed to breathe. With preterm infants, sometimes that prematurity is going to result in kind of periodic respirations. So really kind of short periods of apnea. So they call it apnea prematurity for that reason. Apnea is abnormal if it's greater than 15 seconds. So usually 10, 15 seconds of apnea is going to be followed by the patient trying to compensate by breathing really fast. And, a lot of times they have bradycardias as well. So typically these are caused by those immature controls of respiratory drive. So the baby doesn't understand, baby's brain um, uh, doesn't understand when it's supposed to tell the body to breathe more. Okay. So typically, apnea prematurity usually is more of a central apnea because it's that central response telling us not to breathe, not as much of like obstructive apnea, which is your brain is telling us to breathe, but there's a blockage in your upper airway. Okay, so what do we do for treatment of this? The big one is continuous monitoring of that heart rate and respiratory rate. I cover this actually in your diagnostics lecture a little bit with apnea monitoring in the home care setting. Babies go home with apnea monitors frequently if they have apnea prematurity, so that we're alerted in the home of any apneas so the baby can get stimulated. So typically, if your apnea monitor goes off, alerting you to the fact the baby's not breathing, gentle stimulation is enough to kind of remind them, hey, wake up, you're supposed to be doing something, take a breath. So we do that by flicking this foot, rubbing the skin. You can kind of pick the baby up and pat them on the back. Those are kind of uh, typical, easy treatments to correct the apnea. There's other treatment strategies that are mentioned in your book in table 35.3. So, you know, any precipitating factors that might be um, uh, causing the issues need to be removed. Again, that's tactile stimulation. When they're in the hospital, we usually treat them initially with CPAP. Um, rarely would you think that a baby would go home with CPAP for apnea prematurity. They just probably keep them in the hospital until they didn't need the CPAP anymore, before sending them home, because this is something that gets corrected as the baby grows up. They will grow out of this. Theophylline or caffeine, these are your kind of, stimulant medications. This is going to increase your respiratory center input, and that they enhance diaphragm strength. So theophylline is one example of that medication class, and caffeine is the other. So that is always a very good MBRC question that I feel like they like to ask. So these agents, again, stimulate that nervous system, stimulate the diaphragm, tries to get the baby to breathe. Another method that we use is the back to sleep method. So this was initiated quite a few years ago to try to help reduce sudden infant death syndrome from apnea, because of those weak neck muscles, large head size positioning. They thought that putting your baby on your belly to go to sleep was going to increase CO2 retention and apneas. So that was a big movement. When I was a baby, we always got put to bed on our bellies. My kids, I was taught a lot during my maternal classes to not put my baby on its belly to sleep, but to put them on their back. Another part of that back to sleep movement is to just remove a lot of the fun things that we want to put in our baby's cribs as decorations, but removing a lot of that, like pillows, stuffies, mattress things, those um, crib wraps. I can't remember what that's called, but any type of blanketing or anything like that, you should minimize all of that in your baby's crib. So really, it is bare minimum inside the crib with the baby sleeping, just because when they're so very little, they have a hard time. They're not able to pick up their head or move it. So you want to make sure that they're not gonna accidentally asphyxiate themselves on their teddy bear. Yes. So I didn't cover really a lot in the lecture about sudden infant death syndrome, but your book does cover this as well. Sudden infant death syndrome, just main takeaway is just causes are really unknown. There doesn't need to have that apnea of prematurity to be a predisposing factor. Kind of, we really don't understand how that happens. So really they want you to kind of think of some preventative measures. So high risk babies are gonna be on monitors at home. They want us to train family members for apnea monitoring. Like I said, they recommend babies putting that supine on their back or sideways position for the first 6 months of life. Reduce any soft objects in the baby's sleeping environment. Um, um, I think that's smoking also, I think, is another one that is kind of a precursor or a risk factor. So you want to try to make sure that you're giving good smoking cessation information to mom. But unfortunately, this is always the saddest phone call that we'll get as RTs is the 8 o'clock in the morning phone call to come to ED for a medical emergent of an infant found unresponsive at home. It usually means that they pass sometime in the night, and there's usually not a lot that you can do at that point. All right, so that ended the first part of this lecture on a super sad note, and you guys can come back for part two, where we're going to start talking about pulmonary vascular diseases.